Welcome back to the Deep Dive. We're here to help you, the learner, really get a handle on complex topics with, let's say, surgical precision. Today, we're tackling something foundational. It's biology, it's pathology, it's about sexual development and what happens when things don't quite line up. Sexual ambiguity. And look, if you really want to master the language before diving into the genetics, and believe me, the genetics get incredibly complex, this is essential groundwork. We're pulling from classic pathology sources that demand real clarity on definitions. Specifically, we need a common language for two key terms, true hermaphroditism and pseudohermaphroditism. They often get, well, mixed up.
They really do. And the precision you mentioned, it's absolutely non-negotiable here. Our sources are very clear right from the start. This whole area of sexual ambiguity is, and I quote, exceedingly complex. Trying to talk about specific syndromes without this basic vocabulary firmly in place, it just leads to confusion. We really can't rush the setup. So our mission today, really, is to get that foundational structure clear. We need to understand that biological sex isn't just, a simple on-off switch. It's actually defined by 4 distinct criteria, 4 measurable things that normally align during development.
And when they don't align.
That's it. Clinically speaking, sexual ambiguity is simply a disagreement, as the source puts it, among those 4 criteria.
Right. So we're not immediately jumping into the why the specific gene glitches or enzyme problems, not yet. We're focusing first on the what, the structural conflict itself.
Exactly. We're building the framework. If we skip this step, then all the conditions that follow, Klinefelter syndrome, congenital adrenal hyperplasia, they just become a list of names without context.
Yeah.
By setting up these 4 pillars, we give you, the learner, a kind of scaffold. It lets you immediately see where in the developmental process the issue occurred.
Makes sense. A scaffold. I like that. Okay, let's unpack the structure then. The sources say sex is defined on several levels, 4 levels, you said. And ambiguity happens when these levels give conflicting reports.
Precise.
Maybe think of it like assessing a new building. You've got 4 different inspectors. One checks the blueprints, another checks the structural integrity, a third checks the plumbing and electrical, and the 4th looks at the finished exterior.
That's a great analogy.
If all 4 inspectors sign off saying, yep, this matches the plan, it's solid, everything works, looks right, then the building's identity is clear. But if, say, the plumbing inspector says, hold on, this doesn't match the blueprints, or the exterior looks completely different from the plans, then the building status is ambiguous, right?
Exactly. Our 4 pillars are those inspectors. And that analogy works perfectly as we start with the absolute foundation. Pillar 1, genetic sex.
The blueprints in your analogy. So what defines genetic sex?
Pillar 1, genetic sex. It's
Yep.
purely about the chromosomes, specifically the presence or absence of a Y chromosome. XX means genetically female. XY means genetically male. It's the simplest, the earliest, and the most fundamental criterion. And our sources stress something here that's absolutely critical to grasp. The Y chromosome, its presence, is both necessary and sufficient to kick off male development.
Necessary and sufficient.
Yes, the text is definitive. No matter how many X chromosomes are present, a single Y chromosome dictates testicular development and a genetic male sex.
Wow, okay, that's a huge point right there. So even with chromosomal variations like 47,000 XXY Klinefelter syndrome, which the source mentions, that individual is still classified as genetically male because that single Y chromosome sort of won the initial biological lottery.
It did. It set the whole developmental cascade in motion towards male. The problems in Klinefelter happen later because of that extra X, but the genetic definition, pillar 1, is male, determined by the Y.
Got it. The Y fixes the genetic identity right at the start. It gives the initial command.
Right. So if genetic sex is the blueprint, then pillar 2 is, well, maybe the primary engine that the blueprint specifies. That's gonadal sex.
Gonadal sex, how's that defined?
This one's based on the histologic characteristics of the gonads.
Yeah.
Basically, what tissue is actually there under the microscope? Is it ovary? Is it testes? Or in some cases, is it a mix of both? This is really the primary internal determinant because the gonads make the hormones that shape almost everything else that follows.
The hormone factory.
Pretty much.
Yeah.
And here's something really fascinating, something that often surprises people learning this. The underlying biological default state.
A default.
Yeah. Early on, the embryo has what we call indifferent gonads. They haven't committed yet. And the inherent tendency of this tissue, this is in both XY and XX embryos, mind you, is to develop along the female pathway, to become ovaries.
Wait, so becoming female is the default path?
It is. Feminization is, in a way, the passive state, the path of least resistance, biologically speaking.
So to get a male outcome, the body has to actively intervene. It has to stop that default process.
Exactly. Masculinization is the active process. It takes energy, specific signals. It needs that Y chromosome to turn on a specific gene, the SRY gene sex-determining region Y. SRY is like the ignition key. It pushes that indifferent gonad to become testicular tissue.
And if SRY is missing, or mutated, or just doesn't switch on properly,
Then the default takes over. The tissue follows its inherent tendency and develops into an ovary.
okay.
This really highlights how critical the gonad is. Pillar 2. It's a major fork in the road. Once that tissue differentiates, it sets the course.
That totally reframes how I think about it. It's not about flipping a male switch on. It's more like the Y chromosome has to successfully trigger a whole series of complex events just to stop the default female development.
You got it. That's a much more accurate picture.
Okay, so we have the blueprint genetic and the engine, Gonadal. What's next? Pillar 3 must be about what that engine actually does, right? You called it the plumbing.
Right, ductal sex. Pillar 3. This is about the internal reproductive plumbing, the architecture inside. It depends on which of two early embryonic duct systems develops and which one disappears. There are the müllerian ducts, which can become the uterus, fallopian tubes, and upper vagina.
Okay, the female internal parts?
Yes. And then there are the wolffian ducts, which can become the epididymis, vas deferens, seminal vesicles, the male internal parts. And importantly, both sets of ducts are present initially in the early embryo, regardless of whether it's XX or XY.
Both are there at the start. So something has to decide which set stays and which goes. What makes that call?
It's all down to the hormones produced by the gonads once they've differentiated pillar 2 again. Specifically, it's about what the testes do. If testes develop, they very quickly become little endocrine factories. They start pumping out two crucial substances.
Okay, what are they?
First, there's müllerian inhibitory substance, or MIS. Pretty descriptive name.
Yeah, it sounds like it inhibits the müllerian ducts.
Exactly. It causes those potential female internal structures to regress, to wither away. Basically, it eliminates the internal female blueprint. Second, the testes produce testosterone, and testosterone actively stimulates the wolffian ducts, causing them to develop and mature into the male internal reproductive tract.
So MIS clears the way, testosterone builds the male plumbing. What happens if the embryo is female with ovaries? Or what if testes are there, but they don't make MIS or testosterone correctly?
Good questions. In a typical female embryo, the ovaries don't produce significant amounts of MIS or testosterone at this stage. So without MIS, the müllerian ducts aren't inhibited. They just passively develop into the uterus, tubes, etc.
Following the default again?
Kind of, yes. And without the strong testosterone signal, the wolffian ducts aren't stimulated. So they just passively regress. They fade away.
So the fate of the internal plumbing, pillar 3, depends entirely on the signals coming from pillar 2, the gonads.
Absolutely.
Which means a disagreement here could cause major issues. Like, what if you had testes that made testosterone but not MIS?
That's a known scenario. You potentially end up with both male internal ducts developing due to testosterone and female internal ducts persisting due to lack of MIS. That's a significant internal ambiguity right there.
Wow. Okay. Blueprint, engine, plumbing. What's the last pillar?
The final step, pillar 4, phenotypic or genital sex.
Ah, right. This is the outside appearance, the part everyone sees.
Exactly. It's based purely on the appearance of the external genitalia. Is the presentation typically male, typically female, or is it somewhere in between ambiguous?
This is where, as you said earlier, it gets really interesting, because this is what most people just call sex. But it's only one piece of the puzzle.
It's the final, observable outcome of that whole cascade we just walked through. The blueprint, the engine, the plumbing, they all contribute to this external presentation. But, and this is crucial, it can also be the most misleading pillar when there's ambiguity.
How so?
Because the development of external genitalia is driven mainly by androgens, particularly testosterone, but even more so by its more potent derivative, dihydrotestosterone, or DHT.
DHT.
So imagine a scenario. An XY individual develops tests. Pillar 1 and 2 are male. The testes make MIS, so the female ducts regress. They also make testosterone, so that male internal ducts, pillar 3, develop. Everything seems on track for male.
Right.
But what if the enzyme needed to convert testosterone to the more potent DHT is missing or deficient?
Ah, so the signal isn't strong enough for the external parts.
Precisely. DHT is really needed for full masculinization of the external genitalia. Without enough DHT activity, the external structures might fail to masculinize fully or at all. So you get a pillars 1, 2, and 3 all aligned as male, but pillar 4, the external appearance, ends up looking ambiguous or even typically female.
That's a major
Great
disagreement.
classic disagreement. And
Yeah.
understanding that kind of conflict is exactly why we need these precise clinical definitions we're about to get into.
Right, so we've established the framework. Ambiguity arises from disagreement among the 4 pillars. Now, for clinical classification, specifically for true hermaphroditism versus pseudohermaphroditism, everything hinges on the state of pillar 2. Gonadal sex. The gonad itself, the tissue type.
The gonad is the anchor point for these definitions. It's considered the source of the fundamental biological identity for these classifications.
Okay, let's start with true hermaphroditism. Sounds dramatic, but you're saying the definition is actually quite strict.
Very strict. According to the classic pathology texts we're drawing from, the term true hermaphrodite is reserved only for individuals who have both ovarian tissue and testicular tissue present within their body. It's a fundamental issue right at the level of gonadal differentiation itself. Pillar 2 is inherently mixed.
So it's purely a histological diagnosis. It comes down to what the pathologist sees under the microscope.
Absolutely. You need evidence of both ovarian structures like follicles and testicular structures like seminiferous tubules coexisting in that individual.
How does that usually manifest? Is it like one ovary and one testis?
That's one possibility. The tissue mix can show up in a few ways, which kind of highlights the complexity. You can have what's called an ovotestis. That's a single gonad, emerged gland that contains patches of both ovarian and testicular tissue.
One gland doing double duty?
Sort of. Or, as you suggested, you might find a distinct ovary on one side of the body and a distinct testis on the other side.
Okay.
Less commonly, someone might have ovotests on both sides. But in every scenario, the defining feature is that coexistence of both ovarian and testicular tissue lines. The gonad itself is mixed.
Wow. So the body's main hormone engine, the gonad, is basically running 2 different conflicting operating systems at the same time.
That's a good way to put it.
That must create some serious hormonal confusion downstream, right?
Certainly does. You've got ovarian tissue trying to send out female signals, estrogens, and testicular tissue trying to send out male signals, androgens, MIS.
Like a hormonal civil war.
Pretty much. And as a result, the development of the internal ducts, pillar 3, and the external genitalia, pillar 4, is often highly variable and frequently ambiguous. You might see development of both müllerian and wolffian duct derivatives internally, for example.
Okay. So true hermaphroditism is a problem with the core engine itself. It's a mixed engine. That means pseudohermaphroditism must be different.
Yeah.
Is that where the engine is like clearly one type, but the downstream signals get messed up?
That's the perfect distinction. Pseudohermaphroditism accounts for, well, the vast majority of cases of sexual ambiguity that clinicians see. And it represents that disagreement we talked about earlier, a conflict between the phenotypic sex, pillar 4, the external look, and the clearly defined gonadal sex, pillar 2, the actual tissue type.
This is where I think learners often get confused. Why pseudo? It sounds a bit dated, maybe? If someone has tests but looks female, why not just say they have, I don't know, an endocrine disorder affecting development? Why hang everything on the gonad?
That's a really important question. And the terminology, while perhaps sounding old-fashioned to some, has deep roots in pathology and clinical management for very practical reasons. The gonad pillar 2 is the primary source of the body's sex hormones throughout life. And critically, it's also the primary site of potential tumor risk associated with these conditions.
Ah, tumor risk. Okay.
By classifying the patient based on the gonad, we immediately flag the true internal hormonal potential and, crucially, the specific long-term health risks, especially malignancy risk. The term pseudo basically signals. The internal core, the gonad, is clearly defined as either ovary or testes, but the external appearance, the phenotype, is misleading or doesn't match.
So if we just went by external appearance, we might miss a serious underlying risk.
Precisely. For example, someone might look externally female, but internally have undescended testes. Those undescended, often dysgenetic tests carry a significantly higher lifetime risk of developing cancer compared to a normal ovary. The classification system prioritizes flagging that internal reality and its clinical consequences.
Okay, that makes sense from a clinical safety perspective. So the defining feature of pseudohermaphroditism is clarity at the gonadal level. It's definitely ovaries or tests, never both mixed together like in true hermaphroditism.
Correct.
Which naturally leads to 2 distinct types, right? Based on which type of gonad is present. Let's start with the female pseudohermaphrodite. Okay, if the name is based on the gonad, a female pseudohermaphrodite must have ovaries. Pillar 2 is female.
Correct. Ovaries are present.
But the pseudo part means the phenotype disagrees. So they present with male-looking or ambiguous external genitalia. Pillar 4 looks male or unclear.
Exactly. Ovaries internally, but external virilization. This scenario implies that development went along the typical female path. Initially, ovaries formed, müllerian ducts likely developed because there was no MIS from testes. But then later in development, something exposed the fetus's external genitalia to an abnormal amount or timing of androgens masculinizing hormones.
Androgens from where, if not from testes?
Well, the source avoids naming specific syndromes. But clinically, the most common cause involves the adrenal glands going into overdrive and producing excess androgens.
Ah, the adrenals.
Yes. So you get this flood of masculinizing hormones from outside the gonads, which then acts on the external genital tissues and causes them to develop in a male-like direction, overriding the underlying female genetic and gonadal sex.
So the external look is masculinized, but the internal reality, ovaries, potential uterus, is female. Got it. Ovaries plus male-like external genitalia.
That's female pseudohermaphroditism.
Okay, then the flip side. Male pseudohermaphrodite. Following the same logic, this individual must have testicular tissue. Pillar 2 is male.
Correct. Testes are present. Genetic sex is XY.
But the phenotype disagrees. So they present with female-looking or ambiguous external genitalia. Pillar 4 looks female or unclear.
Precisely. Testicular tissue internally, but external appearance is female-like or ambiguous. This is really a classic case of failure somewhere downstream in the masculinization cascade. The initial steps worked. Y chromosome present, SRY gene activated, indifferent gonad became a testis. Pillar 1 and 2 are male. And usually that testis is making the right hormones, at least initially, MIS and testosterone.
So the internal male ducts might even form okay.
Often, yes. The MIS causes the müllerian ducts to regress, and testosterone might stimulate the wolffian ducts. So pillar 3 could also be male. But the problem arises when those hormonal signals fail to properly masculinize the external tissues. Pillar 4 development goes awry.
And where does that failure usually happen? Is it that the testes don't make enough hormone or the body can't use the hormone?
It can be either, or sometimes a combination. You might have an enzyme deficiency blocking the production of testosterone, or, more crucially, the conversion of testosterone to that potent DHT we mentioned.
Right, the DHT needed for external parts.
Or, very commonly, it's a receptor problem. The hormones are being made just fine, but the target tissues, the external genitalia, lack the proper receptors to hear the message. They're insensitive to the androgens. There's a well-known condition illustrating this, where tissues are completely insensitive to testosterone and DHT, even though the testes are producing plenty.
So what happens externally then?
Well, MIS from the testes still works, so the uterus and tubes usually regress. But because the external structures need that strong androgen signal, especially DHT, to become male, and the tissues can't respond, the external development defaults towards a female appearance.
Defaults female again. So the definition is testicular tissue plus female-type genitalia.
Correct. The internal body, in terms of gonad and often duct regression, knows it's male, but the external package looks female.
Okay, this nomenclature, it really forces you back to the gonad every time. If you see female pseudohermaphrodite on a chart, you instantly know this patient has ovaries. And the clinical thinking, the risks, the management, it all starts from that fact, no matter what the person looks like externally.
That's the clinical power of these definitions, even if the terminology evolves over time. It anchors the diagnosis in the underlying biology and risk profile. And now I think we can really see why we spent that time setting up the 4 pillars. It wasn't just academic. If we connect this back, every single type of sexual ambiguity is basically a failure at a specific point in that developmental cascade, starting with pillar 1, genetic, running through gonadal and ductal, and ending at pillar 4, phenotypic.
Right. And for you, the learner, this framework is invaluable. It's like a diagnostic map. It takes you beyond just memorizing condition names. When we encounter those chromosomal variations we touched on, like 47,000 XXY, again, the framework helps instantly categorize where the ambiguity primarily lies.
Exactly. Take 47,000 XXY, Klinefelter syndrome. Genetically, it's male, pillar 1, due to the Y. Gonadal, it's typically male. Testes develop, pillar 2. Ductally, MIS usually works, so müllerian ducts regress, pillar 3, often male. The primary failure in Klinefelter often manifests later, sometimes not fully until puberty or adulthood. It affects hormonal function leading to hypogonadism and subsequently the phenotype, pillar 4, things like poor beard growth, gynecomastia, breast development.
So the ambiguity there is more about incomplete hormonal execution and phenotypic expression, even though the initial sex determination steps were male.
Precisely. It's a failure often at the level of testicular function later on, impacting pillar 4. The framework helps pinpoint that.
So let's ask the big so what question for the learner. We know there's newer terminology like disorders of sex development or DSD, which often focuses more on the underlying genetic or hormonal cause. Why is it still so important, as our sources emphasize, to really internalize these classic pathological definitions, true versus pseudo, anchored by the gonad? Why stick with this?
That really hits the nail on the head regarding clinical utility. While the DSD nomenclature is incredibly useful, especially for understanding etiology, the true pseudo distinction, grounded in the 4 pillars and especially pillar 2, remains vital for the pathologist, the surgeon, the endocrinologist. Basically, for immediate clinical management.
How so? Give us a practical example.
Okay, think about the difference between discovering someone has an ovotestis that's true hermaphroditism versus finding out they have ovaries but were exposed to excess androgens, making them a female pseudohermaphrodite.
Right, different gonadal situations.
Fundamentally different. And that difference dictates immediate critical decisions. In the case of the ovotestis, true hermaphroditism, you have 2 competing types of gonadal tissue wrestling in one place. That mixed tissue is inherently unstable. It carries a significantly elevated risk of developing germ cell tumors cancer. So its presence demands immediate consideration for removal.
Wow. So the term true hermaphroditism instantly flags a high intrinsic cancer risk within the gonad itself, demanding urgent action.
Yes. It's a life-saving shorthand, in a way. True primary gonadal problem with inherent instability and tumor risk. Requires histological confirmation and often resection.
Okay, that's clear. What about pseudohermaphroditism?
Well, take the male pseudohermaphrodite example again. Maybe they have testes, but those tests fail to descend properly into the scrotum cryptorchidism, which is common in these developmental disruptions.
Undescended test.
Right. Now, those undescended tests, even though they are purely tests histologically, also carry a significantly increased risk of malignancy later in life compared to normally descended testes. So classifying the patient as a male pseudohermaphrodite based on the gonad, testes, instantly flags the need to locate those tests, assess their status, and plan for long-term surveillance or surgical management, orchiopexy or removal, specifically because of that cancer risk associated with their location and potential dysgenesis.
So, in both cases, the classification points directly to a specific type of clinical risk tied to the gonad itself, either its mixed nature or its location and development. Exactly. It's like going back to the building analogy. True hermaphroditism is like finding the main power transformer is wired completely wrong, mixing circuits inherently dangerous, risk of fire, needs immediate shutdown and replacement.
Okay.
Pseudohermaphroditism is more like the main power supply is fine, it's clearly 120V or 240V, not both, but maybe the wiring to one floor is faulty or an appliance is broken and causing shorts. The problem is downstream, but still needs specific investigation and repair based on knowing what the primary power source should be doing.
That helps clarify. True is a problem of the source differentiating incorrectly. Pseudo is a problem downstream production, delivery, or reception of the signals from a correctly differentiated source.
You've got it.
Yeah.
And without that clear separation, grounded in the gonadal histology, discussions about risk, prognosis, and treatment can become really muddled.
It's also really important we circle back to something the source explicitly states, especially for listeners new to this complex area. Yes, absolutely. We need to be very clear. While we focused heavily on these clinical definitions based on the 4 pillars and the resulting ambiguity, the underlying genetic causes for all these conditions are, as the source material states, quite variable and beyond the scope of our discussion here.
So the why is complex and varied.
Extremely varied. It can range from mutations in a single gene affecting one specific enzyme to big structural changes in chromosomes and many things in between. But the core message from our sources today is that the pathology, the structure of the ambiguity, has to be defined first. We use the 4 criteria to pinpoint where the developmental conflict occurred. That's the essential first step before you can even begin to effectively investigate the specific, often complex genetic or hormonal cause.
So being able to say, this patient fits the definition of male pseudohermaphroditism due to a conflict between gonadal and phenotypic sex tells you which hormonal pathways failed, which then guides the search for the underlying reason.
Precisely. It focuses the investigation.
Okay, this has been definitely a deep dive,
Yeah.
and a necessary one into biological precision. We've moved beyond just labels to hopefully a much richer, multi-layered grasp of how this biological conflict is structured. Hashtag outro, final takeaway. So, wrapping this up, the big takeaway today is that biological sex isn't binary in its development. It's a complex, coordinated cascade. It's defined by these four key parameters. And ambiguity arises when those four levels, genetic, gonadal, ductal, and phenotypic, simply fail to align correctly during that intricate process.
Well said. And if we just loop back one last time to maybe the most powerful biological insight, we discussed that inherent tendency towards feminization.
The default state.
Right, the default state. It really prompts a final thought for you, the listener, to mull over. Think about it. The body's baseline trajectory, without active intervention, is towards developing ovaries and female internal and external structures. That's the passive path. Now, consider the sheer number of things that have to go exactly right, in perfect sequence and timing, to achieve a fully aligned male outcome. You need the Y chromosome. You need SRY to activate correctly. You need the testes to then produce MIS at the right time in the right amount. You need them to produce testosterone. You need testosterone converted effectively to DHT. And then all the target tissues have to have working receptors to respond correctly to those androgen signals.
That's a lot of steps, a lot of potential points of failure.
An incredible number of steps, all required just to interrupt that default female pathway and successfully complete the male alignment across all four pillars. And maybe this inherent complexity, this fragility, helps explain why disorders related to failed or incomplete masculinization seem relatively common clinically. The pathway is just intrinsically more complex, more vulnerable to disruption at multiple points compared to the more default female developmental pathway.
That's a fascinating perspective. The sheer biological effort required for masculinization versus the robustness of the default.
Something to think about. It highlights the incredible orchestration involved in development and why understanding these definitions is so critical when that orchestration falters.